A patient bursts through the ER doors, uh, clutching their face, screaming in agony.
Right.
Their coworker shouts they were just splashed with industrial cleaner minutes ago.
Right.
And you have exactly 10 minutes to make a decision that will either save their vision or, leave them permanently blind.
Yeah, it's terrifying.
It is. Welcome to the Revision Deep Dive, designed specifically for you, the plastic surgery resident preparing for board exams like the FRCS. We are skipping the banter today.
Straight to business.
Exactly. Our mission is a rapid-fire, high-yield Q&A on the clinical pathology and management of chemical burns. Before we hit the first scenario, hit the follow button right now so you never miss a revision session.
Absolutely do that.
And if you learned something valuable today, rate the show. Also, definitely grab a premium subscription to access our exclusive journal club and clinical cases, deep dives. You need every advantage you can get. So let's just dive right into the material.
Let's do it. Chemical burns are incredibly high stakes. Whether you're in the trauma bay or sitting across from an FRCS examiner, any hesitation with your algorithms can be fatal.
Right, because it's not like a thermal burn.
No, not at all. That's the critical conceptual shift you have to make. With a thermal burn, the heat transfers, the source is removed, and, well, the primary tissue damage is done.
The inflammatory cascade continues, but the burn itself is over.
Exactly. But a chemical agent, it assumes ongoing activity. It continues to cause active, progressive cellular destruction until you completely physically remove it or chemically neutralize it.
And that ongoing activity is dictated by the specific mechanism of injury, right? Which dictates the pathophysiology, which then dictates your immediate threat level.
Yeah, you can't just list the 6 primary mechanisms for the examiner. You have to know what's happening at the cellular level.
Like how these chemicals actually destroy tissue.
Oh.
Let's start with oxidation.
Right, so sodium hypochlorite is your classic oxidizing agent. At the cellular level, the chemical is aggressively stealing electrons from the tissue's structural proteins and lipid bilayers.
Wow, just stealing electrons.
Yeah, and this electron theft rapidly destroys the cell membrane integrity. So the cell literally lyses and spills its contents.
Okay, so the opposite side of that coin would be reduction, I assume, like with hydrochloric acid.
You got it. With reduction, the chemical is donating electrons to the tissue, and this forces the reduction of amide linkages in the cellular proteins.
So it basically breaks the protein bonds apart.
Precisely. It leads to widespread denaturation and cellular death.
Got it. Then we have corrosion, which is typically phenol.
Yeah, phenol. It's notorious because it acts as a direct solvent. It just dissolves the lipid bilayers of the cell walls right on contact.
So instant direct destruction. What about protoplasm poisoning? Because formic acid is the huge board favorite for this one.
Oh, examiners love formic acid. It acts as a metabolic poison. It penetrates the cell and binds directly to intracellular enzymes.
So it shuts down metabolism from the inside.
Yeah, the cell doesn't just rupture, it basically starves and suffocates on a microscopic level.
That is brutal. Okay, fifth is vesiculation, caused by things like dimethyl sulfoxide.
Right, and that mechanism produces severe ischemia and blister formation right at the epidermal junction.
And finally, the sixth one is desiccation. Classic example being sulfuric acid.
Desiccation is, it's violent. Sulfuric acid has this intense affinity for water. It violently extracts water from the cells in a highly exothermic reaction.
So it's ripping the architecture apart with heat and dehydration.
Exactly. Instant dehydration and necrosis.
Okay, so oxidation or reduction, corrosion, protoplasm poisoning, vesiculation, desiccation. Now, moving past those, we hit the classic board exam dichotomy, the great divide, alkali versus acid.
The big ones.
Right. And the analogy I always use for you listening is an acid burn is like a frontal assault that builds a wall to stop itself, while an alkali burn is a stealth attack that sneaks past the defenses.
That's a great way to think about it.
Let's look at the stealth attack first. Alkali burns, so household cleaners, fertilizers, wet cement, they cause liquefactive necrosis.
And for the exam, the danger isn't just knowing the mechanism, it's the surgical reality of liquefactive necrosis.
Which is a nightmare, right?
A total nightmare. Because the alkali is saponifying the fats and liquefying the tissue, you don't get a hard Escher. You're left with this soupy, poorly demarcated wound bed.
Making clean margins basically impossible to find.
Exactly. And initially, an alkali burn often looks way less dramatic than an acid burn. There's no dark Escher, So inexperienced clinicians get lulled into a false sense of security.
It's deceptive. The barriers are gone, allowing for deeper continuous penetration, which is why ocular alkali burns are an extreme drop-everything emergency.
Oh, absolutely. The rapid corneal penetration is devastating. The liquefactive process melts right through the stroma.
Leading to scarring and opacification.
Yeah, and ultimately perforation of the globe if you don't intervene super aggressively.
Right. So switching to the acid frontal assault. Acid burns cause coagulative necrosis.
Yes. The acid denatures the tissue proteins, they coagulate, and they form that tough, leathery eschar.
Right, which builds the wall, for my analogy. It acts as a physical barrier that limits deeper penetration. But, and this is key, that wall does not buy you time.
No, you still have a strict 10-minute window. Acid burns have to be copiously irrigated within 10 minutes to minimize deep damage.
And you have to look beyond just the skin, like with hydrochloric acid fumes.
Right, respiratory threat. You can irrigate the skin perfectly, but if you miss the rapid airway edema and pneumonitis from inhalation, you lose the patient.
Okay, so baseline rules established. Alkali is liquefactive, acid is coagulative. Now let's dive into the exceptions, because examiners exclusively test the rule breakers.
They really do.
Let's talk about hydrofluoric acid, or HF. It literally has acid in the name. You'd expect straightforward coagulative necrosis. Yet, a tiny drop on the skin can be fatal. Why?
Because HF presents a dual-threat pathophysiology, you have to articulate this clearly for the boards. When HF hits the tissue, it dissociates. The hydrogen ions cause your standard acid burn, the superficial coagulative necrosis. But that surface burn is just a distraction. The real danger is the free fluoride ions.
The fluoride ion is basically a Trojan horse. It uses the mild surface burn to smuggle a systemic metabolic poison deep into the bloodstream.
Exactly. The free fluoride ions penetrate deeply, causing extensive local and systemic liquefactive necrosis.
Wait, so it's an acid causing a liquefactive process?
Yes. Once it's systemic, fluoride binds aggressively to calcium and magnesium in the blood. It rapidly depletes the body's stores, throwing the patient into profound systemic hypocalcemia and hypermagnesemia.
And it attacks the cellular pumps, right? It poisons the sodium-potassium ATPase pump.
Right, and when you shut down that pump, potassium inevitably flows out of the cells. You get a massive potassium efflux.
So you have hypocalcemia, hypomagnesemia, and hyperkalemia. That triad is terrifying.
It's a recipe for fatal cardiac dysrhythmias. In the trauma bay, an ECG is absolutely mandatory. You were looking specifically for a prolongation of the QT interval.
The harbinger of sudden cardiac death.
Exactly. And concurrently, you must draw labs and start 4V infusions to replace the calcium and magnesium.
But wait, if the fluoride ions are systemic, why do our local management protocols focus so heavily on topical treatments? Shouldn't we just push IV calcium and ignore the finger?
You have to do both. If you ignore the local wound, you lose source control. The topical treatment isn't just for the local tissue, it stops the ongoing systemic absorption.
Okay, so after copious irrigation, what's the topical move?
You apply a topical 10% calcium gluconate gel directly to the burn. It provides exogenous calcium that binds and inactivates the free fluoride ions locally before they hit the bloodstream.
And that gel also helps with the intense pain. HF burns are excruciating. If the patient says the pain is coming back, that's your clinical indicator that free fluoride ions are still active.
Right, they're unbound and destroying tissue, so you reapply the gel.
But what if it's refractory? What if the gel isn't enough?
Then you step up. The next move is subcutaneous infiltration of calcium gluconate. And for the FRCS, quote, this exact dosage. 0.5 milliliters of 10% calcium gluconate per square centimeter of affected tissue.
0.5 mil per square centimeter. But practically speaking, what if this is on a digit? You can't pump that much fluid into a tight fascial compartment like a finger.
No, you'll cause iatrogenic compartment syndrome and necrose the digit from pressure alone.
So what's the alternative for a finger?
You pivot to regional delivery. Intra-arterial infusion of calcium solutions. This delivers the neutralizer directly to the vascular bed, binding the fluoride without elevating compartment pressures.
Brilliant. Okay, let's shift gears to another bizarre, highly tested agent. Phosphorus, found in fireworks, firearms, fertilizers. The terrifying thing here is it spontaneously ignites in the air.
Yeah, so the immediate step is copious water irrigation. Not just to dilute, but because the continuous flow of water creates a physical barrier. It deprives the phosphorus of oxygen so it stops combusting.
But water alone isn't the board answer, right?
No. The specific chemical intervention examiners want is a 0.5% copper sulfate solution.
Because the copper sulfate impedes the oxidation process. But more importantly for you as the surgeon, it turns the phosphorus particles black.
Which is huge. Have you ever tried to debride a messy wound bed under loupes? Spotting tiny chemical fragments is nearly impossible.
Yeah, so turning them black basically paints the target, allowing you to easily identify and surgically excise them.
Exactly. So we've covered the weird outliers. Now we need to synthesize this into the rock-solid 8-step trauma bay algorithm.
And highlight the traps, where standard treatment will actually harm the patient. Step 1. Immediate removal of clothing and the agent. But what's the massive trap here?
Never pull contaminated clothing over the patient's head.
Never.
If you pull a chemical-soaked shirt over their head, you're dragging an active, concentrated chemical directly across their face and into their eyes.
You instantly turn a torso burn into a blinding ocular emergency. Just take the shears and cut it off.
Cut it off. Step 2 is copious irrigation for at least 1 to 2 hours. And check the pH of the effluent fluid to ensure adequacy, irrigating until it normalizes.
But here is the biggest trap of the entire exam. Water irrigation is the gold standard, but if you put water on these specific high-yield exceptions, you will fail the scenario.
Fail immediately.
Exception 1. Elemental metals, like sodium, potassium, and lithium.
Right. If you irrigate elemental sodium with water, you trigger an explosive exothermic reaction. It will literally ignite and explode on the patient's skin.
So if the examiner gives you an elemental lithium burn, what's the protocol?
If there's an active fire, use a Class D fire extinguisher. Once it's out, cover the metal entirely with mineral oil.
Mineral oil.
Yeah.
Because it creates an impermeable seal.
Exactly. Isolating it from ambient moisture or water on the skin, preventing ignition until you can surgically remove it.
Exception 2. Phenol, the corrosion agent.
Phenol is not water-soluble. Irrigating it just spreads a highly corrosive chemical across healthy tissue without diluting it. You have to use 50% polyethylene glycol to safely remove it.
50% PEG. Got it. Exception 3. Concentrated sulfuric or hydrochloric acid.
These are a massive thermal threat. Water directly on concentrated sulfuric acid produces a violent exothermic reaction. You'll inflict a severe thermal burn right on top of the chemical injury.
So how do you manage it safely?
Neutralize the concentrated acid with soap before you irrigate. Standard soap has weak sodium hydroxide, which safely neutralizes the acid without that violent heat release. Then you can proceed with water.
Amazing. Okay, assuming you avoided those catastrophic traps, step 3 involves specific decontaminants. The highest yield one is diphoterine.
Diphoterine is incredible. It's an amphoteric, chelating molecule. It's engineered to capture acids, bases, oxidizing agents, vesicants, irritants, solvents.
Basically a universal chemical sponge.
Exactly. And it's completely safe for the skin and directly in the eyes. Early application decreases burn severity, reduces pain, and leaves a shallower burn requiring fewer debridements.
Okay, step 4 is treating systemic toxicity, which we covered extensively with HF. Step 5 is a meticulous physical exam.
Your secondary survey. You have to hunt for traces of residual chemical and hiding spots, examine the nail beds, deepen the hair follicles, and the web spaces of fingers and toes.
Step 6 is the ocular injury protocol. Any suspected ocular involvement means urgent, continuous irrigation and an immediate opto review.
And for the exam, specify that continuous irrigation is achieved using a Morgan lens. It's effectively a contact lens connected to IV tubing for constant hands-free flushing.
Step 7. Mandatory toxicology consult. As plastic surgeons, we manage tissue. Toxicologists have access to specific newly developed antidotes for obscure compounds that aren't in our textbooks.
Right. Don't try to be a hero. Call Toxis.
And finally, step 8 bridges to definitive surgical care. Once decontaminated, treat it like a thermal burn. Perform early excision of necrotic tissue if needed to halt the inflammatory cascades.
If you master this progression, the exam scenarios lose their intimidation factor. The underlying mechanism dictates every single step of your algorithm.
Absolutely. Listen, I will leave you with a final thought to mull over as you prep for your oral boards. Consider what we unpacked regarding hydrofluoric acid.
Yeah.
Think about how a single tiny drop of that chemical on the tip of a finger doesn't just cause local tissue destruction.
Yeah, it's so much bigger than that.
It fundamentally alters their cardiac electrophysiology. It drains their serum calcium, poisons cellular pumps, and slowly, quietly prolongs that QT interval on the monitor while everyone is distracted by the injured hand.
It's terrifying.
It is a stark reminder that in chemical burns, the cutaneous injury you see is very often just the gateway to a profound, unseen, systemic metabolic crisis. Keep that respect for the unseen pathology at the forefront of your mind.
Well said.
If this deep dive clarified a difficult concept, leave a comment or a question below. We want to hear how you're applying this revision material. Rate the show, hit follow, and grab that premium subscription right now to unlock the Journal Club and the Clinical Cases deep dives. You have the knowledge at Go Execute.